Hello everyone, welcome to Tooth Fairy. In this video today, we are going to discuss a template which asks for the treatment plan for the management of the patient. So let us have a look at the question. It says, which of the following should be included in the treatment plan for the management of this patient? So take care of two things. It is asking for the treatment plan for the management of this patient, not a particular condition, but for this patient. That means that you have to go to the case history and you look for everything you can see, like let's say any kind of allergies, any kind of history of any medication, any kind of any history of, let's say, endocarditis, any allergy to any of the NSAIDs. So you have to take care of each and everything and then come back and answer this question because it is asking for an overall management of the patient. And in the options for this template, there are certain treatment options which are given, which we will select according to all the conditions present in the case history. Okay, so as we move on, it will be more clear. Let us see what all options are we talking about here. First is prophylactic antibiotics. Then is confirming that the patient's HbA1c level is less than 7%. Obtain a recent INR before a surgical procedure. Anxiolytic sedative drug administration. Prophylactic nitroglycerin. Avoid NSAIDs. Avoid opioids. Avoid epinephrine. Minimize the use of epinephrine. Avoid local anesthetic. Stop current medication prior to appointment. Delay routine treatments. Treat at the end of the day. Must treat in a hospital facility. None of the above. Now there are 2 or 3 options which we are not going to select at all. And rest we will discuss one by one when to choose which option according to which condition. So let us begin with the prophylactic antibiotics. Let us move on to our next slide. Prophylactic antibiotics. Now what is prophylactic antibiotics? It means the use of antibiotic before any surgical or dental procedure, and it is done to prevent any bacterial infection. Now there are 2 things we have to consider. There are certain procedures which will require antibiotic prophylaxis, and there are certain conditions which require antibiotic prophylaxis. Here we are going to discuss certain conditions in which we will require prophylactic antibiotics. Now, only those patients who are at greatest risk of developing infective endocarditis should receive this preventive antibiotic therapy before any dental procedure. Now, what is infective endocarditis? It means the infection of endocardium, which is the inner lining of the heart valves. A person is at increased risk of endocarditis infection when the patient has certain cardiac conditions. So try to understand the correlation. If a patient has certain cardiac conditions, the risk of infective endocarditis increases. And for that, we use antibiotic prophylaxis. So now we will look at those certain cardiac conditions which will increase the risk of endocarditis, for which we have to use this treatment. First of all, let us say if in the case history it is mentioned that the patient previously had an episode of infective endocarditis in his life, then you will give him prophylactic antibiotics before starting his dental procedure. So whenever you see the history of infective endocarditis in the patient's history, you will treat the patient by giving him prophylactic antibiotic before starting his dental treatment. Now, the other cardiac conditions which we are talking about are congenital heart diseases which can lead to cyanosis. So these are called cyanotic congenital heart disease. What does that mean? It means those heart conditions which are present since birth. And these include, you have to memorize these certain conditions by heart. You have to memorize their names, because if you see this in the case history, you can think about prophylactic antibiotics, whether to choose this option or no. So how will you memorize this? You will memorize it as 5 T's PE. That means there are 5 conditions which starts from T, and one is from P and another one is from E. So in total we have to memorize 7 congenital heart diseases which can lead to cyanosis. 5 T's are tetralogy of Fallot, truncus arteriosus, tricuspid atresia, transposition of great arteries, total anomalous venous return, pulmonary atresia, and Epstein's malformation. If you have some idea about these conditions, then it will be better for you. Otherwise, you don't have to dig in the details for these conditions, because if you see the name and you know that this is a congenital heart condition which can lead to cyanosis, so you have to use this prophylactic antibiotics. It will solve the purpose. But these are not really that difficult. Like, we know transposition of great arteries. What does that mean? I mean, the name gives it away. We know there are 2 great arteries, and transposition means the position of the arteries is reversed, and it leads to inadequate supply of oxygen-rich blood, and that leads to cyanosis. So that is how you can just from the name make out what condition, how does it leading to cyanosis. So memorize these names. Now, when you have these conditions, you have to consider further 3 things. That if the patient is having these conditions, and let's say the patient, it is including that it is unrepaired or incompletely repaired cyanotic congenital heart disease or heart defect, then you will choose this option. If a patient comes to you with this condition but it has been treated, so there is completely repaired heart defect, but the patient is coming to you after 6 months from the repair of this condition, then you will not give prophylactic antibiotics. But if the patient is coming to you within 6 months, you have to treat him before with this prophylactic antibiotic. That is, you have to give him prophylactic antibiotics and then treat him. Another is residual defect at prostatic patch site or prostatic device. If the repair has been done but still there is some residual defect, then you will choose this option. Then you will give. So in short, when you have congenital heart diseases, these certain conditions, 5 T's PE, and it is incompletely repaired or not at all repaired, you will choose antibiotic prophylaxis. If it is completely repaired and the patient comes to you within 6 months, you will choose prophylactic antibiotics. Patient comes to you after 6 months of completely repaired, then you do not have to give prophylactic antibiotics. And if there is still some residual defect even after treatment at the prostatic site, then you again have to give the prophylactic antibiotic. The next is cardiac transplantation. When you see in the case history, it is mentioned that the patient had a cardiac transplant and it developed a problem in the heart valve, then you will choose prophylactic antibiotics. That is cardiac valvulopathy in cardiac transplant patient, you will choose this option. But if a patient comes to you with a successful cardiac transplantation, you do not have to choose this option. One thing which we left here is prostatic heart valve. Let's say if people who should take antibiotic include, like if a person has prostatic cardiac valve, or prostatic material is used for his cardiac valve repair, so if there is processes involved, you will give that patient prophylactic antibiotic. So this is all about the conditions which require this treatment, this antibiotic, before their dental treatment. Moving on to next. Now we have certain procedures which require the use of antibiotic prophylaxis. So it is recommended for dental procedures which involve the manipulation of gingival tissue, periapical region, and plus where you anticipate there will be bleeding involved. So in those procedures, you will choose antibiotic prophylaxis. Example is, let's say a patient is at most risk to infective endocarditis, and the treatment which you are planning to do is subgingival scaling and root planning. You will choose antibiotic prophylaxis because Bleeding is anticipated here, and there is manipulation of gingiva as well, and periapical region as well. So you have to think accordingly. Then suture removal. So these are the procedures which will require antibiotic prophylaxis. So I'm just gonna read it out. Subgingival scaling and root planning, suture removal, biopsy, implant placement, replantation of avulsed teeth, endo surgery beyond, like endodontic treatment or surgery beyond apex, ortho bands placement. Remember, not bracket, because it is not interfering with your gingiva or anything. So ortho bands placement, not bracket. Just remember this thing. And intraligamentary and intraosseous injection, not the normal LEs which we give. Intraligamentary and intraosseous. Tooth extraction and perio procedures such as curating, probing, periosurgery, subgingival placement of antibiotic fibers and strip. So keep in mind that all the procedures which require manipulation of gingival tissue, periapical region, and plus where bleeding is anticipated, you will give antibiotic prophylaxis. Moving on to, now there are certain conditions for which earlier antibiotic prophylaxis was used, but now it is not required anymore. So these are the conditions you have to take care that these conditions do not require antibiotic prophylaxis, even if these conditions are mentioned in the case history. So let's say if in the case history it says that mitral valve prolapse with or without regurgitation, you do not need to give antibiotic prophylaxis. Rheumatic heart disease, mitral valve prolapse, bicuspid valve disease, calcified aortic stenosis, joint replacement surgery. Sometimes in the history it is given that patient had knee replacement done, but you do not have to give any antibiotic prophylaxis. And other congenital heart conditions as ventricular septal defect, atrial septal defect, hypertrophic cardiomyopathy. In these conditions, you do not have to give antibiotic prophylaxis. So just remember those conditions as history of infective endocarditis and 5 T's PEE and cardiac transplantation, cardiac transplantation with valvulopathy. In those conditions, you will give antibiotic prophylaxis, not for these conditions. Please memorize these. Moving on to the next slide. Now, what is the antibiotic regimen for prophylaxis? We know it is different from the regular prescription of antibiotics. What is this now? First of all, these are given 30 to 60 minutes before any procedure. Now, if we have an adult patient and he can take the oral dose, then we will give him amoxicillin 2 grams 30 or 60 minutes before the procedure. And if that patient cannot take it orally, let's say he's unconscious or he cannot take oral medicine, then ampicillin 2 grams IM or IV. For children, oral dose is amoxicillin 50 mg per kg, and if child can't take orally, ampicillin 50 mg per kg. If the patient is allergic to penicillin, then in adults it's clindamycin 600 mg or azithromycin 500 mg. For children, clindamycin is 20 mg per kg and azithromycin 15 mg per kg. We have to calculate for child according to the weight. Now the thing is that for antibiotic prophylaxis, it is very important to take care of the history that if the patient is already taking antibiotic, if let's say if a patient is already taking some antibiotic regimen with an antibiotic which you will recommend him for infective endocarditis prophylaxis for a procedure, so the patient should be given an antibiotic which should be from a different class rather than increasing the dose. So you have to give, if you have to do the procedure and you have to give him antibiotic, you have to give the different class, not increase, like you should not increase the dose of the same antibiotic, but give the different class. And if possible, delay the dental procedure at least 10 days after completion of antibiotic regimen, so that the patient has enough, so that it has enough time that flora can be re-established. So there are two things in front of you. First is you wait for at least 10 days after completion of antibiotic regimen so that the flora gets re-established. Another is if you have to do the procedure and patient was taking antibiotic which you are prescribing for prophylaxis, you are recommending for prophylaxis, don't give him the same class, give him a different class of antibiotic. That's all you have to memorize in this slide for this thing, antibiotic prophylaxis. Moving on to next slide. Now we're just going to have an overview of the antibiotic prescription. We will cover antibiotic prescription later in another video, but here we're just going to have a look on this thing. Now first is antibiotics is not a substitute in the dental treatment. If you can establish a drainage, antibiotic is not a substitute. When do we use antibiotic? Whenever we have any systemic signs such as cellulitis, trismus, lymphadenopathy, patient is immunocompromised, malaise, fever. So these are the 6 signs. When patient is having any of these, then you have to give him antibiotic. For a pregnant patient, penicillin, amoxicillin, clindamycin are the safest drug. Remember these things. And you have to take care of the drug interactions as well. Like if a patient is taking alcohol, like you have to read the history very carefully. If the patient is taking alcohol, warfarin, lithium, you will not give macrolides class of antibiotic as erythromycin or so. No macrolides if the patient is taking anticonvulsants like carbamazepine, benzodiazepine, cyclosporin, warfarin, prednisone, and digoxin. You have to learn these things. Now, what are the important points here? Now, we are going to say that in case of children, penicillin is always the first line of the drug, first line of antibiotics. If not available or if not in the option, or let's say not in the option, then give amoxicillin. For adults, amoxicillin is the first line if no allergies are there. The dose of penicillin, as we know, it's 300 to 600 mg 4 times a day. And for amoxicillin, it's 250 to 500 mg thrice a day. And if there is any allergy to amoxicillin, you can give clindamycin, which is 150 to 300 mg. Now, if amoxicillin is insufficient, or let's say patient has been taking amoxicillin and it is not getting any better, then you can add metronidazole to the amoxicillin, or you can give a combination of amoxicillin plus cloberonate. So these were just important pointers which I have added over here, but we will discuss these in detail later. Moving slide. So the option is confirming patient's HbA1c level, that is glycosylated HB, glycosylated hemoglobin is less than 7%. So whenever you see diabetes in the history, look for this option. It tells you about long-standing condition of diabetes or not. If HbA1c level is less than 7%, it is controlled diabetes. If HbA1c level is more than 7%, it is long-standing, it is uncontrolled diabetes. And if it is uncontrolled diabetes, the patient here is immunocompromised. So antibiotics should be prescribed to him in this case. And generally you delay routine treatment if it is uncontrolled conditions. So if uncontrolled diabetes, you will choose delay routine treatment as well. Moving on to next, obtain or resend INR before a surgical procedure. Look in the case history. If it says that patient is on warfarin therapy, then look for this option. Okay, this is important. If the patient is on warfarin therapy, you're trying to obtain the recent INR before going for any surgical procedure. Now you have to take care of the values if the values are given. Now the normal values are 2.5 to 3.5. If INR is less than 2.5, you can treat the patient. If INR value is 2.5 to 3.5, 2.5 is included in 2.5 to 3.5. When INR less than 2.5, it means till 2.4. So when it includes from 2.5 to 3.5, You can treat the patient, but you have to consult the physician as well. So what you will do is you will consult physician and then treat the patient. If INR is more than 3.5, then you will defer the elective treatment. Now, warfarin, what is warfarin? Warfarin is an anticoagulant, as we know. So if the patient has a history of warfarin, take care of the following things: that you will give no aspirin to the patient. That means no NSAIDs, no metronidazole, no erythro, no clarithrol. Confirm INR level, and depending upon the INR level, you have to. So this is just an overview that if you see warfarin therapy in a case history, what all things you have to consider. Recent INR, you will not give aspirin to that. You will take care of this drug interaction, that you will not give aspirin, you will not give metronidazole, you will not give erythro, clarithrol to the patient. That is all about this condition. Let us move about this thing, warfarin. Let us move to choose this option. On to next, this is avoid NSAIDs. Now what is NSAID? These are non-steroidal anti-inflammatory drugs. When do you have to avoid? These are painkillers, these are analgesics, and when do you have to avoid these? When it is given in the case history that patient is suffering from gastric ulceration, inflammatory bowel disease, let's say Crohn's disease, ulcerative colitis, you will avoid NSAIDs. Whenever there is bleeding disorder, our patient is taking anticoagulants, so you will not give him non-steroidal anti-inflammatory drugs. When the patient is having severe asthma, nasal polyps, or aspirin-induced asthma, you will not give NSAIDs. Asthma, no NSAIDs. Gastric ulceration, inflammatory bowel disease, Crohn's ulcerative colitis, no NSAIDs. Congestive heart failure, avoid NSAIDs. When a patient is allergic to NSAID or aspirin, you will avoid NSAIDs. When a patient, this is very important, when a patient is on high dose of methotrexate. What is methotrexate? It is an anti-neoplastic drug. So when a patient is taking anti-neoplastic dose of a drug, okay, when a patient is taking methotrexate, can be used in cancer or rheumatoid arthritis as well, but the dosage varies. So if the patient is taking anti-neoplastic dose or high dose of methotrexate, then you will avoid NSAIDs. And if the patient is taking low dose of methotrexate, that is for rheumatoid arthritis, you will not choose this option. So this can be asked in any kind of way, like let's say it can be given in the case history that patient is taking high dose of methotrexate, or it can be said that patient is taking anti-neoplastic dose of methotrexate. So you have to make it out whether, if methotrexate is given, whether it is used for anti-neoplastic or rheumatoid arthritis. Then if the patient is on lithium, then also avoid NSAIDs. Digoxin in older individuals or end-stage renal disease, choose this option. Late-term pregnancy, choose this option. For aspirin, now this is specifically for aspirin. If the patient is taking oral sulfonylurea for diabetes mellitus type 2, avoid NSAIDs. Third trimester of pregnancy, you will avoid NSAIDs. We have read this for this thing. So these are all the conditions which you have to memorize to avoid NSAIDs, where to choose this option. Sorry. Now let us discuss a bit about the NSAIDs and acetaminophen. The thing is, it depends upon what kind of pain a person is experiencing. If a person is experiencing mild pain, then acetaminophen is the drug of choice. Now, acetaminophen has an antibiotic and analgesic, that is, it will reduce your fever, it will reduce your pain, but it does not have any inflammatory effect, anti-inflammatory effect, sorry. So acetaminophen is having antibiotic and analgesic, but no anti-inflammatory effect. Maximum dose for acetaminophen is 4000 mg per day. Dose is 325 to 1000 mg. And for children, 10 to 15 mg per kg is the drug of, is like acetaminophen can be given. Now, if the pain is moderate to severe, then NSAIDs is indicated, like acetaminophen will not work. Only acetaminophen will not work. So NSAIDs are indicated. Example, Brufen. Give Brufen 400 mg Q4H. Ask the patient to take it 4 hours. As and when required, it is not a regimen. Or any other NSAID. Like there is no choice when it comes to NSAIDs. If acetaminophen, after that ibuprofen, like we will discuss in details. When it comes to NSAID, there is nothing called the choice first, second, third choice of NSAIDs. Like no acetaminophen, any NSAIDs can be given. If allergic to aspirin or NSAIDs, or let's say NSAID is contraindicated because of some condition, you can give that patient acetaminophen and codeine, because only acetaminophen will not work and only opioid you will not give. So you will give a combination for moderate to severe pain, because you cannot give NSAID. In children, NSAID is, you can give, let's say, Brufen as 10 mg per kg Q6 to 8 hours. If the age is above 12, codeine can be added to acetaminophen or Brufen, depending upon the options which are listed in the template. Now, if the pain is severe pain, you can give high dose of NSAIDs. Let's say Brufen 600 mg. Remember previously in the moderate or severe pain, in moderate to severe category, we have given ibuprofen as 400 mg and here we are giving 600 mg. And you can add codeine as well, 30 to 60 mg to NSAID or acetaminophen, and oxycodone can also be given, and when the combination of oxycodone and acetaminophen, it is called Percocet. So this is, you just have to have an idea about this thing. We'll discuss in the prescription part. Moving on. Avoid opioids. This is avoid opioids. As we know, opioids are also used for to alleviate the pain. So when a patient has certain conditions, let's say COPD, which is chronic obstructive pulmonary disease, in which the airflow is restricted, so patient complains of, wheezing, difficulty breathing, shortness of breath, these kind of symptoms, and there is chronic bronchitis, emphysema, you have to avoid opioids, because these cannot be given in these conditions. Like you do not have to, you have to avoid opioids. Another is if patient is taking MAO inhibitors, that is monoamino oxidase inhibitors. When a patient is taking monoamine oxidase inhibitors, these are antidepressants, then meperidine, which is an opioid, is a contraindication. Even if the patient has stopped MAO inhibitors 2 to 3 weeks before taking meperidine, it is still contraindicated. So remember this thing, MAO inhibitors and meperidine is contraindicated. Now the third point is when a patient is opioid drug abuser. So here you have to know a bit about, about relative and absolute contraindications. You should know about this thing. So the thing is that when patient is, let's say, opioid drug user, let's say patient is an abuser, and NSAIDs can be given to the patient. There is no contraindications to NSAIDs, no allergy to NSAIDs as such. In that case, opioids become absolute contraindications, as we have an option of NSAIDs available for us. So we will try to prescribe NSAIDs other than opioids. So here it becomes absolute contraindication. But let's say if a patient is an opioid drug user and NSAIDs are contraindicated, then you have to avoid NSAID because it is contraindicated or it is allergic, and then opioids become a relative contraindications because patient is having severe pain and you do not have any other option. So in that case you will give opioids to that patient. So this is important. If NSAIDs can be given, then avoid opioids in this case. So look for treatment alternatives. What else can be given in such conditions? If you do not have an alternative, opioids become relative contraindication, and if there is alternative, then it is absolute contraindication, avoided. Now next is avoid epinephrine. This is slightly debatable because some says that you should never choose it and some says that uncontrolled hyperthyroidism, you have to choose it. Next is which is very important. It's minimize the use of epinephrine. Minimize the use of epinephrine in all the heart conditions, whether it is hypertension, angina, MI, congestive heart failure, arrhythmia. You have to minimize the use of epinephrine. You have to use this condition. Significant valvular disease, again which leads to cyanosis, 5Ts PE. That means where antibiotic prophylaxis is needed, you will minimize the use of epinephrine. Then hyperthyroidism, you will minimize the use of epinephrine. Then TCAs, you will avoid epinephrine, minimize the use of epinephrine, but if they have asked specifically for levonorepinephrine, you will avoid it completely. Okay, tricyclic antidepressants, if given, then you have to minimize the use of epinephrine, but levonorepinephrine, you have to completely avoid it. Now, if the patient, because TCAs can increase the BP and it can cause cardiac arrhythmia, it can increase the blood pressure. Now, if the patient is taking beta blocker, as beta blockers also increases the blood pressure and epinephrine also increases the blood pressure. So minimize epinephrine whenever patient is taking beta blockers. So minimize it to 0.04 mg or 2 carpules of 1:100,000 epi. Now, if the patient is taking cocaine, minimize epinephrine. But if the patient has taken cocaine 24 hours previously, then there is increased risk of dysarrhythmia and high BP, so avoid it completely in that case. So these are the conditions which you have to take care when you select this option. So take care of hypertension, angina, MI, any of the heart conditions, you will minimize epinephrine. When you have to give the patient an antibiotic prophylaxis, in those conditions, you will minimize the epinephrine as well. In hyperthyroidism as well, tricyclic antidepressants, if a patient is taking these drugs, minimize epinephrine. And if patient is taking beta blockers, minimize it. If patient is taking cocaine, minimize it and avoid it completely if patient has taken it in 24 hours. Moving on, avoid LE. Now, if the patient is allergic to LE, then you have to avoid LE. That is the only thing. If a patient is allergic to LA, then you have to avoid the LA. Now next is, let's say lidocaine. If a patient is allergic to lidocaine, then you have to avoid it. Then stop current medication. Now they say that you will never choose this option. Reason being because we are not entitled to stop current medication which is prescribed by a physician. We can adjust the dose for some, but we cannot stop the current medication altogether. That is, we have to send the patient back to the physician and physician will do it. So we are not going to choose this option ever. Delay routine treatment. Now, when we will delay routine treatment? When the patient is in stage 3 and stage 4 of hypertension, then we will delay routine treatment. When the patient is in stage 3 and stage 4 hypertension, we will delay the routine treatment. We will defer the elective treatment. In uncontrolled diseases, you will delay the routine treatment. Like a patient is having uncontrolled diabetes, and uncontrolled diabetes, when HbA1c is more than 7%. So try to, correlate these things. So uncontrolled diseases, you have to delay the routine treatment, as uncontrolled diabetes, uncontrolled hypertension, uncontrolled hyperthyroidism. You will delay routine treatment. If there is a history, like let's say the patient has recently had MI or any CVA, cerebrovascular accident, and it happened within 1 month of the patient coming to you, then you have to delay the routine treatment. If time has passed, it is more than 1 month, then you can do the routine treatment, but in this case you have to delay. Active flu, you have to delay the routine treatment. First and third trimester of pregnancy, we will delay the routine treatment. So these are the conditions in which you will delay the routine treatment. Now, as far as LA is concerned, we will discuss it in altogether a different lecture, but just to brief, we know that LA is of two kinds, esters and amides, and when there is an allergy to one esters, you cannot use another ester. Okay, so if a patient is allergic to one ester, esters are like procaine, benzocaine, tetracaine. These are the esters. So if a patient is allergic to one esters, you cannot use the another ester, another LA for S from ester class as well. But if a patient is allergic to amide, it does not rule out the use of another amide. That let's say if a patient is allergic to lidocaine, you can use prilocaine, but all this we will discuss in altogether a different lecture. So that was all about this lecture. Thank you so much. Thanks for watching. Thank you, everyone.